So good morning, everyone. So these are my disclosures, sources of grant support, and some consulting work. So in the next 30 minutes, we're going to start off by just describing a bit of the recent data on the opioid epidemic, data from the CDC describing where we are with that. We'll then talk about opioid use during pregnancy and some of the work our group has done looking at patterns of opioid use during pregnancy and some of what's known about the impact of opioid use during pregnancy on various outcomes. In the second half of the talk, we'll shift gears a little bit and talk about opioid prescribing after cesarean delivery, and specifically consider the way in which opioid exposure might be a precipitant for persistent use and misuse, and then how excessive opioid prescribing may be a source of leftover medication, introducing opioids into communities available for diversion and misuse. And then we'll talk about strategies for mitigating some of these risks. So the scope of the opioid problem. So this is what's now become a classic slide describing where we are with the opioid epidemic and how we've gotten there. It's 3 lines. The dotted line shows prescription opioid sales in kilograms per 10,000 from the late 1990s to the late 2000s. And as you can see, during this just 10-year interval, the amount of opioids dispensed into in the US increased approximately 4-fold. The other 2 lines, the hash line, shows substance abuse treatment admissions per 10,000 in the population, also increasing about 4-fold during this interval. And then finally, prescription opioid-related deaths, which also went up 3 to 4-fold in just this 10-year interval. And over the past couple of years, as this issue has gotten more attention on the part of regulators and clinicians, law enforcement, we've seen some curbing in the prescribing rate and even some decrease in recent years. This slide shows the number of prescriptions per 100 persons. You can see there's a slight decrease in 2013, 14, and 15. That said, opioid use and misuse remain incredibly common. These are data from the 2015 National Survey on Drug Use and Health, a representative survey of all Americans. And they estimate that 91.8 million Americans, or 37.8% of adults, used a prescription opioid during 2015. Nearly 5% misused them, and nearly 1% had an opioid use disorder. So this epidemic has hit different communities in different ways. This shows the amount of opioids prescribed per capita at the county level in 2015. There's about a 10-fold variation between counties in the lowest tertile and those in the top tertile. And you can see there are certain geographic regions where there's a lot of counties that have the highest rates of prescribing, the black shaded in counties, including Appalachia, parts of West Virginia, Tennessee, certain parts of northern New England, northern California, the very top of California and Oregon, certain parts of the Midwest. When the CDC looked at the characteristics of the counties with the highest opioid prescribing, it's counties with high proportion of non-Hispanic whites, high proportion of people that are on Medicaid, and a county with high rates of unemployment. So we're increasingly appreciating the relationship between non-medical prescription opioid use and heroin use. This was nicely summarized in this review in the New England Journal. We've recently seen a dramatic increase in heroin and synthetic opioid overdoses, and we know from epidemiologic studies there's about a 40-fold increase in the risk of heroin use in people who have a history of non-medical use of prescription opioids, such that the majority of current heroin users report having used prescription opioids non-medically before they transitioned to heroin. And then finally, these are the most recent overdose data from the CDC showing the trends in opioid overdose from 2000 to 2015. You can see the blue line, the natural and semi-synthetic opioid overdose rate has leveled off in the past couple of years, but at the same time, there's been a dramatic increase in the rates of heroin overdose and more recently, synthetic opioid overdoses from fentanyl, carbfentanyl. And now opioid overdose is the leading cause of death in people under 50 in the United States. This is a real public health crisis. So our group has been interested in looking at the ways in which the epidemic of opioid overuse and misuse extends into pregnancy. Our first foray into this space was this paper published in Anesthesiology back in 2014. And we defined a cohort of commercial insurance beneficiaries, about about 500,000 pregnancies between 2005 and 2011, and then looked at the frequency with which patients were dispensed opioids during pregnancy. And we found remarkably that 14% of women were dispensed a prescription opioid at some point during pregnancy, and you can see the breakdown by trimester. We looked at the indications that were recorded in association with these prescriptions. It was very common pain conditions that occur during pregnancy: back pain, abdominal pain, joint pain. But I'll note that for all of these pain conditions, opioids are not recommended as a first-line therapy, and for many patients there may be other either non-pharmacologic or other non-opioid pharmacologic analgesics that may be just as effective in treating pain or even more effective in treating pain. We replicated the study in a nationwide Medicaid population and found that the rates of opioid prescribing were even higher. So in our cohort of 1.1 million pregnancies from Medicaid, 21.6%, so more than 1 in 5, filled an opioid prescription at some point during pregnancy, and 3% had 30-day supply or more dispensed during pregnancy. Just as we saw there was significant geographic heterogeneity in opioid use outside of pregnancy, we're seeing the same thing during pregnancy with some states, again, West Virginia, Ohio, Tennessee, Georgia, some of the Midwestern states, New Hampshire, all having opioid prescribing rates during pregnancy in excess of 25-30%. And the U.S. really stands out in terms of this prescribing behavior. These I show here some population-based estimates from Canada, Norway, and Scotland. You can see the opioid prescribing rates are much lower than what we're observing in either the Medicaid or the commercially insured population in the U.S. So why is this of concern? Well, what are the consequences of opioid use during pregnancy? Well, there are all of the risks of using opioids outside of pregnancy, the risks of addiction and the other adverse effects associated with opioids, but there are a number of considerations that are unique to pregnancy as well. And the complication that we understand perhaps the most about is neonatal abstinence syndrome. It's a drug withdrawal syndrome in newborns following birth. So when the mothers take opioids, the fetuses are exposed to those opioids, and then when after birth, when the maternal opioids go away, there's a withdrawal syndrome that occurs in the infants. And this is a condition characterized by a wide array of signs and symptoms, some of which are quite serious, but include increased irritability, hypertonia, tremors, feeding intolerance, emesis, watery stools, seizures, and respiratory stress in some extreme cases. This is a tremendous source of healthcare utilization and cost to the healthcare system. A lot of NICUs have large numbers of babies with NAS in them. So we know that there's a very high incidence of NAS in infants born to mothers using illicit opioids or on maintenance therapy with methadone or buprenorphine. But prior to this study from our group, there were no population-based estimates for the risk of NAS in infants born to mothers using prescription opioid analgesics during pregnancy. So this is a study published in the BMJ a couple of years ago. So we were able to, using our Medicaid cohort, estimate that the absolute risk of neonatal abstinence in all parturients who took opioids to be 5.9 per thousand, but this risk goes up by a large amount with patients on higher doses for longer durations, and particularly in association with opioid exposure late in pregnancy. We also found that there were certain effect modifiers for the dose-response relationship. There were certain co-exposures that would significantly augment the risk of NAS, including being exposed to other drugs of abuse, smoking, and the use of other psychotropic medications that themselves may cause a withdrawal syndrome. So we followed up this study in this paper, again published in the BMJ, where we looked at the impact of co-exposure of opioids and particular psychotropic medications. And we found that even after correcting for dose, duration, type of opioid, patients who were co-prescribed antidepressants, benzodiazepines, and gabapentin all had markedly higher rates of infants with neonatal abstinence syndrome. The severity of neonatal abstinence syndrome was also much more severe in patients with these co-exposures. And this is of concern because many women, particularly in the Medicaid population who are prescribed opioids, are on other psychotropic medications. Other potential risks are less well defined, but include potentially birth defects and placentally mediated complications. So regarding birth defects, we know that endogenous opioids are important regulators of growth and development. So there's concern that if a mother consumes exogenous opioids at critical time points during development, this will act on receptors and may increase the risk for congenital malformations. And animal studies in particular point to a potentially toxic effect of opioid exposure on the developing central nervous system. In terms of human data, probably the best done study we have is this study from the CDC's National Birth Defects Prevention Study. It's a case control study where mothers with infants born with malformations are matched to mothers with infants who are born without malformations, and then they interview the mothers about their exposures during pregnancy using a bunch of prompts and different aids to help ensure or try to ensure the reliability of the information. And in this study, they found that the exposure to opioids early in pregnancy was associated with about a twofold increase in the risk of ventricular septal defects, atrioventricular septal defects, hypoplastic left heart, spina bifida, and gastroschisis. A subsequent study from the Sloan birth defects cohort, which is a very similar case control study, found about a twofold increase in the risk of neural tube defects and spina bifida. So these findings, I think, are concerning, but there are a number of limitations in interpreting these data. In particular, with the case control design, there's concern about recall bias. So they're asking mothers about their exposures after they know the outcome of the pregnancy and up to 2 years after delivery. And there's concern that mothers who have infants born with malformations may be more likely to remember their consumption of opioid analgesics than those that have pregnancies that end in a healthy born infant. There's also concern around confounding bias that may not be adequately adjusted for in the analyses, that there are differences between patients who consume opioids and those that don't, that might confound this association and aren't fully adjusted for in the analysis. These associations also emerge in the context of small numbers and multiple testing, so there's the potential for type 1 error. We have virtually no data on specific opioids, the impact of timing, or on dose, and so this is an area where I think really we need better studies. But these are worrisome data, given that about 6% of pregnancies will be exposed to opioids in the US during the first trimester. So in terms of placental complications, there's reason for concern here as well. The human placenta contains opioid receptors. We know that exogenous opioids administered to the mother will stimulate opioid kappa receptors on the placenta, and that this depresses acetylcholine release in studies that have been done. Acetylcholine, in turn, causes dilatation of blood vessels that maintain placental blood flow by the activation of endothelial muscarinic receptors. So there's concern that opioid use may compromise placental blood flow and nutrient transfer via this mechanism. And a number of epidemiologic studies have suggested an association between opioid use during pregnancy and intrauterine growth restriction, placental abruption, stillbirth, and preterm delivery, all placentally mediated complications. But the findings have been varied. The studies are not all of high quality, and again, this is an area where we need to learn more. So much remains to be learned, but given the frequency of exposure, these risks are certainly concerning. That said, we know pain is common during pregnancy, and alternatives to opioids like NSAIDs or other non-opioid analgesics like gabapentin have their own safety issues that have been described in the literature. I think really as a field we need to develop interventions that are non-pharmacologic in nature and promote their use in women who are pregnant. This has been successful outside of pregnancy, and in many studies, non-pharmacologic interventions have been shown to be as good as opioids in treating pain. I think this is an area where there's real opportunity for obstetric anesthesia to expand the scope of our practice to include antepartum pain, to ensure that opioids are used in a judicious manner if women have pain complaints during pregnancy. One of the things I'm excited about that we're doing at the Brigham is one of our faculty members is starting a chronic pain in pregnancy clinic where we'll see patients, evaluate their pain, determine whether they can be addressed without the use of pharmacologic agents, and then if they require pharmacologic agents, making sure that the safest agents are the ones that are prescribed to the patient. Okay, so for the back half of the talk, we're going to switch gears and talk about postpartum pain, particularly post-cesarean pain. So we know that cesarean delivery is the most common inpatient surgery performed in the US. There are about 1.3 million C-sections done each year. Opioids are routinely prescribed in the U.S. following cesarean delivery. About 95% of patients in the U.S. will fill an opioid after their cesarean delivery following discharge. It's thus a potentially important source of opioid exposure for opioid-naive women. So the question comes up, well, how does our approach to postpartum pain management and our use of opioids potentially contribute to the opioid epidemic? And I mentioned at the start of the talk, I think there are really two key considerations. One, that opioid exposure could be a precipitant for persistent use. And second, that excessive prescribing in this setting can lead to leftover medication that's available for diversion or misuse. So we'll take up each of these. So the conceptual framework that we're working with when thinking about opioid prescribing as a trigger for persistent use and misuse is that patients will be appropriately prescribed an opioid for an acute indication like post-cesarean pain. A certain percentage of those patients are going to really like the way the opioids make them feel and are going to go back to their practitioners and try to get additional opioid prescriptions and transition over time into chronic opioid use. This in turn places the patient at risk for non-medical prescription opioid use, and then when the opioids are no longer available or become too expensive, the patients could potentially transition to heroin or synthetic opioids. And this progression is unfortunately played out in the life of this woman, Melissa Morris, who was profiled on All Things Considered back in January of 2017, and I'll read just a bit of her story. So a doctor handed Melissa Morris her first opioid prescription when she was 20 years old. She'd had a cesarean section to deliver her daughter and was sent home with Percocet to relieve post-surgical pain. On an empty stomach, she took one pill and lay down on her bed. I remember thinking to myself, oh my God, is this legal? How can this feel so good? Soon she started taking pills recreationally. She shopped around for doctors who would write new prescriptions, frequenting urgent care clinics where doctors didn't ask a lot of questions or were loose with their prescription pad. Morris's path started with Percocet and Vicodin, commonly prescribed pain medications. When those drugs no longer got her high, she switched to OxyContin. When she then started injecting OxyContin, after that she got her hands on fentanyl patches. She'd chew them instead of applying them to her skin. When doctors got wise to Morris's shopping tactics, her supplies of pills diminished and she turned to heroin instead. So we were interested in asking the question, well, what is the risk that a woman exposed to opioids after cesarean delivery might go on to become a persistent opioid user? So we did a study where we used claims from a commercial insurer, and we defined a cohort of about 80,000 women who are opioid naive, who were dispensed an opioid following their cesarean delivery. We then followed them for 12 months after the delivery and used a statistical method, trajectory models, to define distinct patterns of opioid use in the year following cesarean delivery. So the trajectory models separated the cohort into 5 distinct groups. You can see most of the groups quickly returned down to a low baseline level of opioid filling. But a single group, what we term the persistent users, continued to refill opioids consistently across the year of follow-up. This was 1 in 300 patients in the cohort, so a small fraction of patients. But again, when you think about the fact that there are 1.3 million C-sections, the absolute number of women that are potentially falling into this pattern is quite substantial. We looked at risk factors for being a persistent user and identified younger age, being a smoker, having a history of cocaine abuse, certain pain conditions that occurred during pregnancy like back pain, fibromyalgia, and headache, and then affective disorders as evidenced by antidepressant use or benzodiazepine use. These are many of the same risk factors that have been identified in other populations as risk factors for chronic opioid use and misuse. And I think recognizing that a certain subset, a small subset of patients are at risk for becoming chronic opioid users is important, and really we need to develop interventions in our healthcare systems to identify patients who are starting to make this transition to chronic use, hopefully at the time that they come back for the first refill of opioids so that the process can be arrested early on. So the second issue is excessive prescribing leading to leftover medication. So when we look at the data around where patients or people who use prescription opioids non-medically get their opioids, it turns out that getting them from friends or family members for free is the leading source. So this is data from the Substance Abuse and Mental Health Administration showing the proportion or the percent of users that reported getting opioids from various sources that you see listed here, broken down by the number of days of past year non-medical use. And if you look at the the columns over there on the left, any prescription opioid use in the past year. The gray column is given by a family member or friend for free, presumably from leftover medication. So this is a really important source of opioids that are used non-medically. And so there's concern that if we overprescribe opioids in the acute setting, this will lead to leftover medication. As a consequence, we really need to identify normative opioid requirements following surgical procedures so that our opioid prescribing can be right-sized and to avoid this concern. So we sought to define what normative opioid use is after cesarean delivery in this study that was published in Obstetrics and Gynecology back in the summer. We did a survey study conducted at 6 academic medical centers around the US, MGH, the Brigham, Michigan, Columbia, Wake Forest, and Stanford. So women who underwent a cesarean delivery were contacted by phone 2 weeks after discharge and administered a standardized interview about their use of oral opioids. What we found is the median number of tablets dispensed was 40, mostly for oxycodone 5 milligrams or hydrocodone 5 milligrams. The number consumed was just half of the amount that was dispensed, such that the median number of leftover tablets was 15. And if you scale this up based on the fact that there are 1.3 million C-sections, this means there are about 20 million opioid tablets that are left over just from this surgery alone each year. We asked patients what they did with the leftover medication. Most of the time they held on to the leftovers, and this is something that's been seen in other surgeries as well. Patients tend to hold on to the leftover medication just in case. Another interesting finding that came out of our study is that the more patients were prescribed, the more that they took. And this was independent of their pain scores in the hospital or the conditions that they had, any complications, all of the confounders that we could potentially measure. So the more patients went home with, the more they took. And the thought is really that there's expectation setting. If a patient goes home with a large number of tablets, they assume they're supposed to take them. Whereas if they go home with a smaller amount, they end up consuming a smaller quantity. So we broke down the cohort into tertiles based on the number of pills dispensed into 3 groups. Those that were dispensed less than or equal to 30 tablets, those that got 31 to 40, and then those that got 40 or more tablets. And as you can see, they're with more dispensed, there was more consumed. But interestingly, there was no difference in patient satisfaction across the different amounts dispensed, nor was there a difference in the refill rates. When we looked at pain scores, there was no difference there either. The only thing that increased with more opioids were more opioid-related side effects. So the implications of these data are that we really need to develop strategies to better align what's prescribed with what's needed. It's also, I think, an important implication is that we can, in many instances, prescribe less. We also need to develop strategies to encourage patients to dispose of the excess medication when they finish taking their prescription. So one potential strategy to align what's prescribed with what's needed is the use of shared decision-making, which we piloted in this study, again published in Obstetrics and Gynecology. So shared decision-making has been demonstrated to improve outcomes and patient satisfaction in a variety of clinical settings, but it's not been previously applied to opioid prescribing in the acute pain setting. So we designed a tablet-based, computer-based decision aid that formed the basis of a shared decision-making session. And in that tablet-based decision aid, we provided women information on typical trajectories of pain resolution, so what the pain scores would be at the time of discharge, the first week out, the second week out, as well as data that we had on expected opioid use from the survey study. And this is a couple of screenshots from that decision aid showing the relationship between in-hospital pain scores and the number of tablets patients consumed when they went home, the average number of tablets that patients ended up consuming. So we did a pilot study in 50 patients in which we used this decision aid, and then we allowed patients at the conclusion of the shared decision-making session to select the number of tablets that they wanted to be prescribed up to the standard institutional prescription of 40 tablets. So at the time the study was done, every patient at MGH went home with a prescription for 40 tablets. And what we found is when we gave women the choice and did this shared decision-making intervention, the number of tablets they chose was just half of what they were offered on average. So the median number of tablets chosen was 20. The median number that they consumed was 15. the number of tablets that were left over was much smaller than what we observed in the survey study. We looked at the need for refills. 4 out of the 50 patients required refills, but 3 of them had wound complications where they probably would have needed additional opioids even if they had gone home with the full prescription initially. And 90% reported being satisfied or very satisfied with their pain regimen despite receiving much less than a typical prescription. So we think this might be a promising way to limit the amounts and sort of individually tailor prescribing at the time of discharge to avoid overprescribing. So recently we've been looking at prescribing after vaginal delivery. This is some unpublished data that's currently under review. This is data from a cohort from a commercial insurance population of 1.3 million vaginal deliveries. And remarkably, we found that 28.5% of patients were dispensed an opioid following vaginal delivery within a week of discharge. When the fellow that was working on this project first brought the data to me, I thought there must be a mistake in the code, that there's no way that this could be such a high rate, but it holds up. And this is of concern because we know that pain after vaginal deliveries tends to be mild to moderate in severity and to quickly resolve. When we looked at the amounts that were dispensed, it was quite a large amount. So the median dose was the equivalent of 20 tablets of oxycodone 5 milligrams, and at the 90th percentile, patients were going home with the equivalent of 46 tablets of oxycodone 5 milligrams. So I think this is clearly an area where there's overprescribing. So in terms of future directions, I think one of the things that we're going to need to grapple with as a field is whether oral opioids are routinely needed after cesarean delivery. Do we need to give opioids beyond the neuraxial opioids that we administer at the time of delivery? In Europe, opioids are not routinely used. Patients are treated with NSAIDs and Tylenol. And recent evidence from other clinical settings suggests that opioids may not be more effective for moderate to even severe pain than opioid-sparing regimens. This was, I think, a pretty impactful study that was published in JAMA last year. It was an RCT of 416 patients with acute extremity pain, presenting with a baseline severity of pain of 8.7 out of 10, so severe pain to emergency departments, and they were randomized to one of 4 combinations. So 3 of the combinations contained opioids and 1 was without opioids. There was an ibuprofen and acetaminophen group, the non-opioid group, an oxycodone and acetaminophen group, a hydrocodone and acetaminophen group, and then a codeine and acetaminophen group. Interestingly, there was no difference in the pain scores in the non-opioid group compared to the patients who were treated with opioids. The NSAIDs were just as effective at reducing pain. So I think we need to explore going forward whether we could use a similar approach with cesarean delivery and perhaps eliminate the routine use of opioids in that clinical context as well. So in terms of what we can do now with the data that we have on hand, well, I think the first is you can work with your obstetricians and nurses and midwives to develop institutional guidelines for postpartum pain management. This is really an area where multidisciplinary collaboration is needed. On the inpatient side, we can maximize the use of non-opioid analgesics. There's good data from Stanford and others showing that the use of round-the-clock Tylenol and NSAIDs can reduce the amount of opioids that patients require and improve pain scores. Opioids, I think, should be thought of as rescue medications and not something that are given on a scheduled basis. And this is an area where we really need good postpartum nursing education, so they start to think about the opioids as being used in that context. And then I think we need policies that avoid the use of the routine use of opioids following uncomplicated vaginal deliveries. At the time of discharge, I think this approach of shared decision-making has real promise, and I think is a way you can approach the prescribing of opioids, or your obstetricians can approach the prescribing of opioids, where you give patients an upper limit, but then allow them to choose a smaller amount. If they feel like they're doing just fine with minimal or no opioids, there's no reason to prescribe them 30, 40 tablets. It's important to make a plan for the disposal of leftover opioids with patients. The FDA has a nice tiered system, so if the optimal way to get rid of opioids is to return them in back to the pharmacy or to a drop box, and if that's not available, to throw them out in the trash with unpalatable substances like coffee grinds or cat litter. If the patients are unable to do that, they recommend flushing the leftover medications in the toilet. And so making a plan with the patients about how they're going to get rid of the leftover opioids once they're finished taking them is quite important. Again, it's important not to prescribe opioids following vaginal deliveries, except in patients with complications. And then it's important to encourage patients to continue to use acetaminophen and NSAIDs into the postpartum period as an opioid-sparing approach. And then, as I mentioned before, it's important to be very cautious with refills to identify patients who are like the way the opioids make them feel and are transitioning to this pattern of chronic use, and to arrest that process early in its progression. So with that, thank you very much for your attention.